And this is a little bit of a different topic. I started becoming aware. Obviously, you see things about, companies that approach you and say, oh, come to us, we'll help prevent cyber attacks and things. But I started seeing more articles and journal articles and things that were being written about what's happened and how are we preparing for cyber attacks. And while that's important, I'm not really going to go into that technical side of all the computer side with that. What's more important and what we really want to talk about and share and help each other with is if it happens, and it may be only a matter of when it happens for most of us. I think we all find out there are vulnerabilities in our systems, including at the State Lab of Hygiene. Our proficiency testing division worked with a vendor that had a cyber attack, and so that they were down then with our clients that we had through our proficiency testing program, and they couldn't get at data and they couldn't do a lot of things. So it just happens. But what do we do when it happens, and how do we prepare? What do we have in place now, and what can we maybe do better in the future? So just these couple of intro slides. So let's see, whoops. Turn it on would help, Aaron. Okay, so I don't know how many of you remember back, I think it was July 19th, all of a sudden there were all these articles coming into my email about the Times Square billboards went dark, and TV stations couldn't do their local news, and there were 9/11 disruptions, or 911, I should say, disruptions. Flights were being canceled everywhere, people were being stranded, and it turned out to be something caused by CrowdStrike. And I'm like, what's a CrowdStrike? What is that? And it's actually one of these companies that goes out there and markets a product to prevent cyber attacks and have these things. And yet CrowdStrike had rolled out new software, and when people applied it to their systems, all of a sudden everything started going down, and they ended up with these screens of death everywhere. So there were these technical outages, and it was worldwide chaos that day. Luckily, it didn't last too terribly long, but everything was disrupted, and it really just showed us all how vulnerable we are in our whole society and so many aspects of what we do. And so I went to LabTag and I said, do you think we can talk about this? And I think they all looked at me like I was a little crazy, like, what are we going to say? How are we going to do this? Or what do we have to say? And so anyway, they said they thought it was a good idea, though, because how many of you actually have downtime procedures in your laboratories? Okay, so most of you. Yeah, I did too when I was in the clinical labs. How long does that downtime take you for? What's the expected length of a downtime? How long would it last, do you think? 24 hours, 48, maybe 72 if you're lucky. Yeah, well, unfortunately, sometimes when our facilities get hit, it's not anywhere to 72 hours. It's much longer than that. And so what can we do with the downtime policies that we have now to actually try and deal with a longer downtime, and what do we need to be thinking about? And so that's what we're doing today. And so I want to introduce Renee Pelch and Lisa Buchinger that are here with us from the HSHS system up in the Green Bay area at St. Mary's and St. Vincent's. And they are going to come up and talk about what happened in the downtime that they had to experience in their facility.
Down? We're the lucky ones. Not really. All right, so good afternoon. Like Aaron said, we were invited to come today to kind of talk about some of our own experiences with, excuse me, our extended downtime. We did use some of the literature as well that was used at some of the other regional meetings this month just to kind of use as a reference, because some of the ideas that they had and some of the actions they took we thought were important to address.
Documents in your folder, so you have 2 of the articles that we actually saw. So, and one of them is the one that some of these slides were based off of. So
Yep.
Eric Munson was kind enough to try and do this at the other 2 meetings, and we helped out, and they are brave enough to do it here. So thank you to them both.
Yeah, you're welcome. All right. So one of the main references that you have that's attached in the folder today is a healthcare system, pretty big Southern California system that there was some published articles around. So we didn't obviously publish any articles on our experience. It was just last August, and we were down for 18 days. So we can certainly interject a lot of our experiences, but it is nice to have this reference for you. So we're able to speak to you today referencing these publications and sharing our own personal experience of an extended downtime. The example highlighted here is the large Southern California network in which they, I think, experienced their extended downtime in 2021. So their global costs exceeding $20 billion, and the literature has really discussed the impact on entire healthcare organizations. Their recommendations to really look at your cybersecurity within your healthcare system and the development of a risk inventory, like Aaron's risk assessment. There's a lot of things that go into place that you don't realize that you rely on all your communications, your internet, all of those things. So what is the definition of an actual extended downtime? When we look at that, we think, oh, we're used to our little downtimes when we do computer upgrades, EMR updates monthly, maybe a lab LAS short downtime of 8 hours, those types of experiences. But a full extended downtime really consists of complete shutdown of your major patient care, your operational, your communications, including the EMR, the LAS, pharmacy, scheduling, billing and coding, imaging software, internet, hospital shared drives, payroll, phone systems, and all digital communications. The main focus here is healthcare organizations and the need to improve cybersecurity and the development of that risk inventory. So imagine a healthcare organization as this example. I'm sorry, I went one too many slides. University of Vermont Medical Center, servicing approximately 1 million residents, 6 partner hospitals, and 17 regional laboratories, which produce about 3.2 million test results annually, with all systems down for 25 days. Is your lab prepared for that? Can you manage with your current downtime procedures for 25 days? Our personal experience with extended downtime involved 14 hospitals, more than 45 clinics, and we were down for about 18 days. In this reference, they talked about all the same things, their internet access being down, pharmacy, radiology, supply chain ordering. How do you get supplies when all of your systems are down for ordering for 25 days? Digital communications, phones, faxes. We had no way to communicate within our healthcare system, providers, patients, that you needed to call back for something, critical values, all of those things. And their attack estimated cost is $40 to $50 million, mostly in lost revenue, because you can't even keep track of everything you're doing in that amount of time when you're used to your 8-hour downtime, maybe 24-hour downtime. So in a nutshell, we look at the breakdown of like pre-analytic, analytic, and post-analytic, and how these phases of lab tested were affected. So pre-analytic significantly was affected. Our analytic was relatively limited impact because your analyzers are up running just as normal, but you don't have your systems in place to kind of get everything moving through. And then the post-analytic being significantly affected. So then Renee will talk about the nuts and bolts of the pre-analytic.
All right. So the pre-analytical phase actually made us feel crippled, as if we were blind and deaf and lost all of our senses. And I'm going to explain why. Imagine providers unable to see any existing orders. and lab assistants not being able to see any future orders. So when the outpatients arrived, they were sent home. Not only did we not have pre-printed barcode labels, we didn't have any labels. So our phlebotomists were handwriting names, date of birth on every tube. So imagine the transcription errors. See this comprehensive epic downtime requisition? This is not what we had. Ours was a blank half sheet of paper with lines for patient demographics, and nurses had to handwrite the tests on the sheet. This was one of our greatest obstacles, especially when providers and nurses would write daily ×5 and expect the lab to manage that. Many requisitions did not have a room number or the patient name spelled correctly. Specimen transport. Network servers drive the pneumatic tube station. We were fortunate that ours was still functional, but that's another consideration. There was lack of standardization on how patients were typed into each analyzer. As you know, there are character limitations that contributed to the variance. Paper was everywhere. There were copies of orders, copies of results. We even had to move additional copiers from other departments into the lab to accommodate the massive amounts of copies needed. For those that have automation, our laboratory does not have automation, but for those of you that do, imagine the manual effort to hand deliver specimens, centrifuge, and aliquot. Another fun fact, QC ranges and rules were no longer available. And the volume continued. Our laboratories, the specimens just kept coming. Our lab processes about 4,500 specimens a day. We quickly realized that we did not have the capacity with our existing colleagues, despite colleagues working overtime. Oops, I think I hit it. Oops. Oh, that's it. So I'm gonna go back to what one of the labs did in order to maintain the chaos. They actually implemented bouncers. And these individuals were 24/7, and what they did was reject any orders or specimens that were not acceptable. Our lab did not have the foresight to implement something like this, which we would have wanted to, but we did have runners that would transport specimens, results. These were typically colleagues that were displaced from their current role, such as finance colleagues that we utilized in the lab as our runners. Again, with the automation, you would have to maintain adequate staffing to manually process these specimens as the volume keeps coming. And how does a lab sustain the normal volume of specimens? The answer is simple, you don't. Even if you double your staff, it still would not be enough. Therefore, steps need to be taken to encourage urgent testing only, limited outpatient phlebotomy, and divert specimens to a reference lab. At our hospital, we had to recalibrate the expectations around turnaround times at our incident command center. The aftermath was not only lost revenue, it also left a wake of exhausted colleagues, including Lisa and I, who worked 96 hours a week just to keep the operations going.
So the analytic nuts and bolts, as Renee mentioned, instrumentation was fully functional. we had dedicated hardware. You know, they have dedicated hardware that are not connected to the internet or the interfacing. So we couldn't actually connect anything to our LIS because all systems were down. So any middleware that your, you know, like let's say chemistry equipment has, that was down. So every computer in our lab was actually turned off. So there was no connection there at all. So if you have automation, that temperature monitoring that's built into automation was no longer available to you. So back to the manual temperature checking. And then all of our remote troubleshooting within our instruments and our vendors was non-existent.
There was a significant obstacles that were similar to the pre-analytical that occurred during the post-analytical. One of those was report generation. Along with the patient demographics not showing up on the report, there were abbreviated test names that providers were not familiar with, such as anti-10A. And reference ranges were also absent. There were no flagging or critical values. And honestly, if you were to answer, how many lab techs have all the critical values memorized in your lab? Probably not. So another barrier were the chemistry calculations, automatic add-ons. Reflex testing was not available. Our client services. Initially, all faxing capabilities were down, and we eventually had to share a fax machine with another department down the hall. So we'd be running down the hall, trying to receive faxes and send them out. Walkie-talkies were used in the beginning before they were able to implement iPhones into our department. Prior to the phone lists being distributed, providers would just come to the lab and they would just start asking, where can I get micro results? Where can I find this? Our filing room did not look like this. I'm going to tell you, I wish it did, but the reality is our room was consumed with accordion files of patient results that were filed by date in alphabetical order. One of the labs actually, which I thought was brilliant, came up with these QR codes that had some downtime resources, including their reference ranges. The text handling critical results, we actually created cheat sheets that had the critical results on them. And we could not provide some of the calculated values, so that was being done by hand. Some of the labs actually that we read about discontinued add-on testing. Definitely reflex testing was discontinued. There wasn't an option. So if we would have had the appropriate staffing, we would have created a dedicated results center, but we just did not have the staffing to provide that. There are labs that did in these resources, which I think would be a great idea. We did file by alphabetical order. We separated our inpatient from outpatient results. This is a summary of how many steps it took from specimen receipt to result filing. So each time we received a specimen, this is the map, the decision-making tree that had to be used. Sorry about that. And help was a great word that we used frequently during this time. As we said, we could have doubled our staff and still not had enough, But we were fortunate that we used retired colleagues. We worked with the willing first. We would ask colleagues if they wanted overtime, if they wanted additional hours. And we also worked with our clinic and utilized some of those individuals to come and help us. But it was difficult, even allowing people a day off during the week.
And just one other additional comment on that is our colleagues were super dedicated to supporting each other. So it wasn't like, oh my God, I can't come back here. It's like, what can I do? Do you want me to stay? Should I come in extra tomorrow? So there was that. But I think after like day 7, day 8, day 10, we're like, how much longer are we going to be doing this? This is crazy, because we didn't have really good organizational communication within our health system to let us know what was happening. They basically said, be prepared to do this for 2 weeks. And that was it. And that was like day 2. So just to kind of like a plug for how amazing our team is. And Jeremy's back there, he's our microbiology lead. And I'm going to talk about that area a little bit, because I know we have a lot of those colleagues in here. But microbiology is really one of those things that you don't really worry too much about during a downtime, because you can just wait, right? You're like, oh, you know what, we're going to have a couple hours down. We're just going to wait to set that up. We're going to just wait to put that result in. When you're down for 18 days, 25 days, you got to move on. You can't hold those specimens that long, as you all know. So some of the key take-homes here that I think is in the sheet too as well, that Aaron put that folder together, is really looking, so if you can take anything away today, start now. Don't be naive that it's not going to happen to you, because there's a lot of things that you can work on just to optimize your current downtime procedures. So control incoming test volumes. How can you do that? When you know you're going to be down an extended amount of time, you know you can't sustain that same volume with downtime procedures with your current staff. Standardize that data entry process into analyzers. You know, as Renee said, some of them have character limits, and it was like the Wild West. Like every heme report would look different than a chem report would look different than what we were doing in microbiology. There was no standardization, so very hard to file if you didn't know they were putting last name first name first. It was very difficult, so standardizing how things are manually programmed into your instruments is another key takeaway. Plan for loss of automation and specimen processing. So if you have that in your lab, be prepared for centrifuges, aliquot tubes, pipettes in an area where you maybe don't have a lot of that. The analyzers are reliable. Connectivity is the issue. So make sure you look into, how do we monitor our QC if we use an online resource? Is there a way to print that monthly just so you have something to compare your results to? Posnegs, easy, right? Chemistry results, those ranges change frequently for QC, new lots, things like that. So making sure you have a way that you can make sure your instruments are still functioning appropriately. Have up-to-date, easy paper requisition process. That was one of our huge opportunities for us. Scrambling. We were getting chart notes, half sheets of paper, little scrap pieces of paper in the tube station. Providers wanted to do hemoglobin every 2 hours for 6 days. We're like, no, we aren't doing that. It's one order per time. So just really looking at how you're going to manage that type of request as well. Get a bouncer and result runners. We didn't have the bouncer. We really wish we would have. When we were reading about this and working with Eric, we thought, oh my gosh, why didn't we think of that? That would have been amazing. Turn you away if you don't have the right format of an order or something that we can read. Program reference ranges and critical values in your instruments when possible, so that you can, when you have to turn on your paper process for instrument printing, that's all there for your providers and for your techs. Have enough people and techs to go manual. Think about your team. Who are your willing colleagues, the ones that you know you can rely on, that are gonna like take this challenge head on. Like, I want to be part of this, because they thrive on some of that stuff. Reset your turnaround time expectations. Don't forget about your proficiency testing results, because you still are held to get those in. Access to office supplies, especially paper. We were going through like pallets of paper every other day. Having space to store your results and all your requisitions, and a lot of copy machines. we had lines the first couple of days of colleagues like waiting in line to make copies. We're like, this is a bottleneck. Don't think about this when you're used to your high throughput laboratories that you can, just result. It's different when you have to make copies of every result. And then maintain instrument QC, conduct periodic QA and second checks. One of the things we noticed is that when we were doing the recovery, we never really second checked what we had for orders and what we actually ran. So we had a lot of missing tests that we ran incorrectly, like the wrong test. And at that point, when we were doing recovery, so this was for us in August 27th of last year, and we were back up 18 days later. Our recovery didn't finish until probably the end of December of 2023. So there was no chance to go backwards and try to resolve any of that. Encourage the organization to have access to hotspots. This is one of the things that we got about day 7, and actually really wish we would have thought about it ahead of time. So those are the kinds of questions you can start asking now, like, hey, does our organization have access to hotspots? Because this is the way that we could get into some of our online resources, like online ordering for staples. We needed so many office supplies that we had a hard time doing that, so we actually had to run out to the office stores to get what we needed. So just to have access to some of that internet resources, entering our proficiency testing results. There are other portals that we could get into to start managing some patient information. One of the ones we used was Theradoc because of our IP. So those of you that are IP here, we were able to get in there and actually see some information if we needed it. Keep up with backup data and EMR. If there's any, see what there is. I mean, a lot of us, I think, are on Epic, but I think there's regular backups that can be done so that maybe, can you see future orders? Can you see future appointments? Because we had patients coming in and we're like, what are you here for? We tried to help them, but you're kind of just blind with that. So if there's any kind of backup snapshots that can be done on a regular basis, do that as well. One of our biggest learnings, I think, for this, and one of the first things we worked on when we worked on our lab system downtime is really, for those of you that work in the blood bank or manage a blood bank, having a manual log to track the blood unit activity. So really, we track in the core lab, all the patient stuff, like patient results, patient orders. But for blood bank, it's like you actually need to know the pathway that unit is going each time. So is the unit in the inventory? Is it retyped? Is it set up on this patient, released on this patient, reset on this patient, so that we can have all that tracking. Standard downtime result form for microbiology. So we didn't really have anything for a downtime form for microbiology. So Jeremy, how many modifications did we make on that form during our downtime? Every day. So we first were writing everything. We're like, this is nuts. We can't write every single sensitivity down. So then he kind of created a new sheet that it was you just circled it, if it was resistant or susceptible. So we really tried to streamline that. So that was, I think, a really good, by the end, it was a very good tool that we had, but we did kind of manipulate that over and over from his wife's computer at his house. So that's kind of where we were at with this. Standard downtime result for manual result testing. So anything that's not printed by an instrument, but you manual result in your lab, having those on kind of one form we used, and this is something we created after the fact too, as kind of a follow-up to our downtime, and then having the reference ranges there for all these things. And don't forget about microbiology, because there's a lot of manual result that happens in there too. So we actually added our whole core lab and microbiology common test to that one result form. Finally, file the results by patient name, patient chart. So we first started doing kind of data service, and then alphabetically by data service, and then providers would come down and be like, well, I need this result. Well, what day was it? I don't really know, maybe a couple days ago. We're like, oh my gosh. So when we did the recovery, this was one of our key learnings too. We actually, when we started doing the recovery, we were like, this is crazy. We're gonna have to start finally got by patient. So we brought in volunteers, retired colleagues, and we went through each single day and we started creating charts. And when you have a big hospital that you critical inpatients, you'd have the same patients every day, and day after day after day. So we kind of created lab charts for them. And that was really, really good insight by actually our LAS team, because once they started getting those registrations in, you could take that whole chart and like order all those tests and result them all. And then you're like done with that patient. So that was one of our key learnings really in that recovery process. And we started doing it like towards the end of our downtime just because we couldn't find results on patients when providers were coming to the lab or calling. One of the things we did too is had access to a computer that was not on the networks. We took a computer from like an old retired piece of lab equipment, and our LIS team hooked it up to one of our label printers on WordPad, and like we started creating labels so that our team could go to the inpatient floors and label specimens that were legible and in a standard format. So that's was another key change for us. We used them in microbiology and all of our plates, all of our specimens, so not just like patient draws, but specimens, aliquots, anything that we needed to relabel in the lab. Prioritize patient registrations for recovery. So once our system decided that we were going to focus on that, it was like all systems go. We had basically like a war room where we are all in there as every entity, and they just started coming, registration after registration. So like we'd get these like chart labels printing, and we'd have to go grab it and go in our files and see, oh, do we have this patient? Okay, we do. And then we started like moving them through and resulting the test. So nobody really talks about the recovery, and honestly, there was so much learning in that actually optimized our downtime for future, hopefully not future needs for us, but even just for our shorter downtimes, it would be really helpful. And then be a part of the recovery plan. So, be there when the system's saying, okay, we're gonna start recovery, this is what we're thinking. We were like, wait a second, this isn't gonna work for lab. We gotta have like stickers or something. Like you can't just say, oh, this one's done or this one's done, because they were kind of like flying off that printer once we asked for labels like hotcakes. So this is some of the documents that Aaron has in the folder that you can like learn more about, that we use as some of the reference, or Eric did when he was creating this. But like I said before, one of the key takeaways, if you don't take anything away today, is it's not too late to start looking at your downtime procedures, optimizing your forms, asking your team, can we sustain this for 5, 7, 10, 20 days? So thank you for your time. Do you have any questions?
All right, let's.
Jeremy.
Yeah.
I don't have a question. I was just going to add some stuff just because I was in micro and they were dealing with a ton of other stuff. But as they were talking, you have your downtime forms and whatnot, but just imagine you being not able to even log into a computer. So maybe have a master copy in a binder, like just so if that goes down. As for microbiology, your work cards, first thing I thought of, okay, Bellin Hospital is right next to us. I can't get into our computer. I called Bellin. I walked over there. They had some downtime, like work cards that we could use. So I made a ton of copies. And then susceptibility testing. How are you reporting out those susceptibilities? You could, so we have Moldy and Phoenix. So after a couple days, we finally got that hardwired to be able to connect. But then there's no interps so I went through old results. I looked at the interps for everything because it's things you're probably never even thinking about. So then I said, can't get in a computer. So I went home, made a bunch of copies of your common bacteria, staph, E. coli, Kleb, all your susceptibilities. So hopefully it's a little more streamlined. And then another thing is like when they're talking about is putting results back in, how do you put all those susceptibilities back in? So just things to think about if this would ever happen to anybody. I pray it doesn't, because it was pretty terrible. So
Renee and I say it was worse than us going through COVID.
It was.
Yeah.
So first of all, I have to commend you thank you, and that you survived that.
Yeah, thank you.
That's a lot. You had mentioned that you had incident command. Mm-hmm. Were they helpful because did they help coordinate some of this stuff so you could focus on the lab practices?
Yeah, absolutely. Incident command, we attended twice a day. And they were instrumental in determining the standardized forms that were going to be used. And it was just such a huge communication that we would get all in one place and then be able to take back to our teams. One of the realizations that we had, and it was several days into it, the colleagues were like, we need communication. And it's like, oh, yeah, I guess we're going to have to just write on a whiteboard, like all of the updates. We were so busy. We didn't even think. We were just communicating what needed to be done and managing that. You just forget that, yes, we need to do that. And then every leader was in the room, including our, medical director. So they were able to go back to the teams. And like we said, when we had to recalibrate what the turnaround times are going to look like, or say we can't manage hemoglobins every 2 hours for 5 days on one sheet of paper, they would take that back to their teams. So super helpful and instrumental.
So, and I missed it initially. So this was a cyber attack just on your facility?
On our system.
Did
On
you
our
find
whole
out
system,
on your whole system?
including our clinic partner, Prevea. So it was all of us.
And one last thing, were you able to identify any negative patient outcomes from your downtime?
Not specific to the laboratory, and honestly, I don't really think so, and I don't recall. I mean, if laboratory was involved, we'd probably be involved in some sort of RCA to kind of look at that, but I don't think anything specific to the laboratory. We didn't really mention a lot. I know in these articles that you can take a look at, there was a pretty big handicap for our copath and our pathology team in reports. That was another very big whole nother issue. I mean, we weren't as involved in the pathology area as much as the clinical lab and microbiology, but that could be a whole nother talking discussion, because that was very difficult for especially those critical diagnoses and things like that. One of the things I was remiss to mention in here, not all of our systems just came up at once either. It was like, okay, now we have these phones. Okay, now we have our regular phones. Now we have fax. Now we have, now we might have a portion of our lab system. So it wasn't all of a sudden you're down and you're up. It was this trickling up. So that was a really big challenge, because you had your systems in place for being fully down. Then all of a sudden, the next day, we come in after 2 hours of sleep, and we're like, wait, now this is up? Oh, okay. So our team also, as ambitious as they were, they really wanted to make their own standard process. And so that was kind of frustrating for our team's shift to shift, day to day, what's new today? What's that? So we did implement a daily update, or sometimes it was AM update, PM update with now we have to be prepared to change this process because now we have this tool back. So it wasn't they just brought us all back up at one time.
So you were mentioning earlier about you had to manually track your blood bank disposition, but I was wondering did you have issues with the names of patients receiving blood products? Because I know that I've had issues when we've done emergency releases on patients who weren't alert, that we weren't able to spell their name correctly, and then because we use blood bank vans, we have to do all that authentication of their identification. So how did you deal with that particular issue?
So yes, but we also use blood bank vans. So that's kind of the nice piece to it. So most of this stuff wasn't discovered until we were actually doing recovery, and we'd be like, oh my gosh, this name's been spelled wrong the whole time. But on all of the blood bank documentation, that name was the same. And so then when we got the patient registration, it was kind of a collaborative effort. And it wasn't big things. I mean, maybe it was a little bit of a misspelling of a first name, or I don't believe in the blood bank area we had any date of birth issues, but we did in the core lab clinical area. So sometimes we opted to either not recover that patient chart or the executive decision to do that, depending on how that information matched to throughout the downtime versus the downtime, all of that to the actual registration. So there was a lot of challenges with that, and a lot of that was because of the upfront legibility of how things were being submitted to the lab, handwritten, kind of up for your own interpretation. So there was a lot of challenges with that, yes.
And no electronic cross-matching.
I think blood bank, if you have a big blood bank, it's a real area where you kind of bring that team together and be like, what do we do when we have no lab system? Because so much of your QA checks and the things that you do in there revolve around your system, that you kind of have to go back to like your very basic days of blood banking where everybody's a new patient, every specimen's a new specimen. You don't have access to a lot of that historical data.
I know from at least Epic, I don't know about other vendors, but Epic will do yearly business continuity reviews, and they're always started and kicked off by Epic. So if you're not involved in those, please get involved in those. Can be a complete game changer, because obviously what your IT team thinks you're doing and what your physicians think you're doing and your intake staff think you're doing is almost certainly different than what you are actually doing. So get involved in that. That can be a huge lifesaver in these scenarios. And this obviously isn't just for cyber attacks, it's also for if you get hit by a tornado, or if there's a fire, or if you just have a weird power outage, or an upgrade takes way longer than you expect. So please, please, please get involved in that stuff when you can.
One of the good things about now, we'll have a downtime actually tomorrow with our lab system, is just to do a quick upgrade. It's about 2 hours. Our team's like, psh, that's fine. we got that.
We got it.
Can I ask while I'm walking over to David here, have you guys undergone like a CAP inspection since this whole thing happened, and how did that go?
Yes, very well.
Very well. So they were
went very well.
Understanding then? Or was there not a lot of errors found?
We documented them, just the transcription errors or any corrected reports, in the fashion that we do on a regular day-to-day basis. So, no, there was no sightings or no discussion.
I think they were actually kind of shocked, like, whoa, we need to go back and do some work for their own preparation downtime. Yeah.
I'm just curious, from y'all or from anyone else in the room, looking at this is very daunting to me. And I am curious how modular your downtime plan has to be, because I feel like, well, if my phones are down, I do this, but if my phones and fax is down, then I do this. But if email's up, I could do this other thing. How modular is your plan? Or is it just, there's a caveman plan and a regular operation plan, and you pick and choose from the buffet, whatever works?
We have a caveman plan, and then we have a SunQuest, which is our lab system, our Clinicist now. Clinicist down plan, we have an Epic down plan, and then we have a both down plan. So we kind of like 4, because it's probably going to be an all or nothing if you're to that point of the caveman plan anyway. And if you have phones, amazing, it's fine, But the days that we didn't have phones, it was actually probably the easiest day for us. Easiest 2 days for us, because there was no way for them to be calling like, where's this, where's that? I mean, seriously, it was like providers like showing up like, I really need this pro time, I'd like to discharge this patient. So it was hard when we started getting some of our tools back, because it just became like this, it's in there, a wild, wild west, just phone calls, ringing, I need this, I need that. It's like, we need you to leave us alone.
It was so quiet in the lab, and that was a good thing, but just an overall bad experience of having to go through that.
All right. Any other questions? Yeah.
Thanks for the heads up. We'll recommend, if we ever get to this, to not bring up the phone. Bring up the phones last. Just kidding. I just want to commend you all for getting through it, for all the work. It does sound like very early days crazy COVIDness. And you said it might even be worse. So thanks for maybe revisiting your touches of PTSD to come down here and talk about it. Really appreciate it. I know that other places have experienced similar things, and it's really, not fun to be there, but good to be more prepared. So thanks.
Thank you.
Are there others of you that maybe, if we start looking back the way they broke it down with pre-analytical, analytical, and post-analytical, have any of the rest of you had issues where maybe you've had any of these affected and things that you'd like to share? Because this is really about, it's not about putting the spotlight on them at all. This is about helping you to think forward and so that we can learn from each other, because that is the beauty of our clinical laboratory network. We are so open, we are so honest with each other, and we really help each other so that when we have to face these things, you never feel alone. You've got this great network here that you can go to. And so I do thank so much Renee and Lisa for being here, and Jeremy for sharing things. But there are other things that have happened in the laboratory. I know we heard from at some of the other sites for people who had recent things that happened that they didn't think about with just downtime for longer times. Has anybody else had any other experiences?
So recently, it was back in May, I worked for Ascension, and we were down for 5 weeks. It was definitely worse than COVID days, where everyone's calling for their COVID result. It was hundreds of phone calls a day, barely being able to get by without having to be on the phone the entire day for your entire staff. But something that we did in micro was we had an Excel sheet, and we had all of our patient results in there, and we distributed that Excel sheet to only certain like infection preventionists at the hospitals, hospitalists, infectious disease. So there were a limited number of people who had it, but they were able to help within the 6 hospitals, 10 hospitals that we have, to then distribute that to those specific physicians on the floor. So it was something where real time we were entering, we would send out the Excel sheet once a day, and then from there, from those critical people at different sites, they were able to give our micro results to the floor to make sure people were in isolation. One thing that I do know that like we really kind of discovered after this was like the critical nature of getting those requisitions legible, obviously, but like the collection date and time was key. We found out later some significant events that happened because collection times were not documented, the critical calls were not made, and things were happening. So like just something to take away is like when you start to get that stuff in and on the front end, to just be very aware of like this isn't okay. You can't give us this without date of birth and the collection time and the date and the source, because like you start to process these specimens as if they're going to be okay, and then other things can happen down the road from that. So we're just starting to recover for micro. We have only a few people designated to enter results all day, every day. And I'm one of those people, and so I'm so excited to be here and not in the lab today. But micro was a lot more complicated because it's not just entering numbers or scanning instrument reports. And so they still expect that it's going to take us many, many months to recover from this, because we have over 11,000 results in an Excel sheet that we're trying to enter as the patients get registered. But just some key things is like really on the front end, make sure you set a level of expectation at the command center and things like that of like these things aren't going to be accepted because there is such high risk with certain samples and certain tests.
So did you have access to your email?
Yeah, we had access to our email. So we did have some computers. Most of the computers were working. Most fax machines were not working. So we were able to do some like scanning and emailing type things. So it's not like Epic was down. We had a lot of pharmacy systems that were down, but we didn't have like complete no computer
And
issue.
we didn't have access to our email. We didn't have access to like Microsoft at all. So that would have been like impossible for us to do like the Excel spreadsheet. We could have had a handwritten one that we could maybe have them posted somewhere where they could come to the lab and look at. So that's a really good point.
And just one thing to mention, it's not just the patient names, the misspellings there, it's the doctor's names. You know how doctors write anyway. You can't read what their signatures are, so I know that in one of those articles they talked about having a line added where they had to print their name, because otherwise you don't know where the result goes, who to get it to.
Last 2 comments are really important because I've been part of those business continuity plans, and you are the hub of direct patient care. And so you have to think about the infection prevention team, or what other team, where's your surveillance, how are you maintaining that, who else are key components that need that information that's generated there. So I agree, having input into those continuity plans are huge, and then it's not a one and done. You know, it's almost like your risk assessment every quarter, you keep refreshing those and looking at what's changed, what do I have to proactively address, so.
Yeah, we were so lucky because one of our IPs was an actual former lab colleague MLS, so she was super helpful to us in our downtime. She would like look through results, we'd put things in a folder for them, she'd handle getting it into the WED system or whatever needed to be done to still maintain our surveillance, so that was really good.
So I had a question. You mentioned like reference ranges quick. Were you actually transcribing ranges onto reports or just putting results out without ranges?
No, we actually had, as part of our downtime procedure prior to our downtime, we had pre-printed reference range sheets that we would send with as another piece of paper with our results, and we were like, this is crazy, like, we can't be sending another sheet of paper with all this other paper, so then we started inputting our reference ranges into our actual analyzers, and that's now something that we do. We just brought in some new blood gas analyzers and made sure that our reference ranges were inputted, because so much of that resides in your LAS, but we know that we sometimes need to now print a result to be able to send that, so we try to do that now on any instrument possible.
So then how did you handle gender and age-specific ranges? Were you inputting that into your information, or do you just use kind of the standard adult?
Standard adult.
Okay.
Sorry, let me get through it. It's okay.
Oh, Julie.
Is this live? Okay.
Yeah.
Yeah, I'm also part of the HSHS group that was down, and another takeaway that we encountered, because we send quite a few of our samples up to Green Bay for additional testing that we don't do, was the tracking of microspecimens, tracking of chemistry specimens, and making sure that they received it, and then getting those results back so that we could put them in our system after the recovery. So that's another facet to just kind of consider.
Another thing that was brought up at one of the other meetings is the fact that depending on how much your system goes down, your building access may be down for couriers. So how do they even get those specimens in? You have to have somebody waiting at the doors or somewhere to let them in with the specimens, because they couldn't get in the way they normally would in the building. So there's just a whole lot of things to think about. And while we don't have any great answers today, that's not the point. The point is to help you start thinking about this now and to ask questions. And we have this great listserv out there too. So as you guys go home and start thinking about these things, shoot out something on the listserv and ask other people, what do you think about this? Do you think this would work? Does anybody have experience? So use all of us, work this through together. We are bigger than just any one institution when we all work together in our clinical lab network. So, any other questions, thoughts?
I'm not envious of all of you who've had to go through your event, but I was just wondering, as part of your after action review, I know you're still in the recovery and that's a long range thing, but has anybody thought about, or maybe, and I have not read all these resources that you have up there, and I'm kind of cringing having to listen to everyone's pain point, but is there an effort, or has anybody reached out to like the vendors? So I'm listening to the gentleman over there creating his own, has to go home, have his maybe non-clinical wife input in ranges and ceftriaxone and all these antibiotics, right, for the lab to do RS intermediate. Has anybody thought about reaching out to the vendor? Are there like companies that would say, hey, we'll help you, build some of this?
Actually, right now HSHS is in the process of evaluating our chemistry vendor, and there's been a lot of discussion about this with them. Like, what tools do you have for your down? Do we have backup documents that we can go back in and look? Because like our instruments only hold so much data, and by the time we were back up recovering, some of that was gone already. So do we have regular ways to back up that data? Because then if you could go pull it, it was just so much easier than actually like going through like paper processes for the recovery part. I mean, we had to do paper at the time, but if we could go back into an instrument and find it, and I think we did this with some of our microbiology stuff, we were able to go back in and actually find that patient, and we could just send it through, so then there was so much less manual transcription in the result entry. So it is actually on our forefront as we work with these chemistry vendors, asking those questions. Can we input the reference ranges into the instrument? Because there was so much learning for us that is certainly something. Now, are we going to blast all of our vendors right now and saying, like, what are all of our opportunities? I mean, one of the things that we did with COAG, so we use warfarin ACL tops. They can't print reference ranges on the result when you have to turn instrument printing on, so we actually pre-populated paper in preparation for future downtimes so that we didn't have to send or manually write a result on a different sheet of paper with reference ranges. So then we just load that paper in when we have a downtime, and it just prints the reference ranges right with the results. So there's a lot of things you can do if you really think about it. And because we had to and we went through it, we're like, nope, we're gonna make this part of our COAG. We know we can go back in and retrieve more in microbiology than we could in chemistry. So that is definitely something as we evaluate vendors that we're asking those questions.
Great points. Anything else? Oh, Eric.
Thanks. I'm really sorry for what you guys have gone through, and it's crazy. I would encourage all of you guys to ask your HIT folks how often you get attempted incursions into your system too, because I know the number for our system, and the reality is honestly shocking, right? If you think it's not possible to happen to your organization, the number would blow your mind. And for us at Advocate, ours is 30 billion a month. Wow. So I'm honest, telling you the truth. That's how often it's probably happening. So you do need to be prepared.
And it's interesting too, once your organization goes through something like this, there's so much education and activity that's being shared with our colleagues. Like we have these like little quizzes that you have to take like every week or something like that on cybersecurity and like warning you of different things. We have these, obviously you can like send things to, we have a spam email that if you're not sure of, you send. I send so much stuff to there that sometimes I get like emails back saying, well, why didn't you do this? I'm like, I didn't know I needed to do it. I thought it was spam. Like everybody's afraid, which is probably a good thing. That so many of our colleagues have a much more awareness because we don't want to go through what we just did again. So.
Exactly. No, I think this is really powerful. I hope that you all feel that it's worth spending some time on this today. I just think it's really important. So again, thank you to Lisa and Renee for leading us through this today. I appreciate it so much. And I think this slide, basically what Eric had explained is the article that you have in your folder is the one about the clinical pathology laboratory who reported and was willing to talk about their downtime. Because when these things happen, for the most part, administration doesn't want us to talk about it because they don't want people to know this has happened to them. So I really am thankful that HSHS gave them the permission to do this. And these other articles, there are other articles about other parts that are of the hospital system that are affected in a cyber attack. So there, you can look those up. But we were really wanting to focus on what happens in the laboratory. So that's what that is. But if you just start looking around, you'll find a lot of articles about, and not as many as there could be, I'm sure. So thank you again today. Appreciate it. Thank you. If you've just finished listening to the afternoon sessions from our 2024 WCLN regional meeting, you're going to, and you want to get PACE credit for viewing those recorded sessions, you're going to need to go to the ASCLS CE Organizer website. And then once you get to their website, you're going to be clicking on the tab Other PACE Providers. You'll look through the list of providers that comes up, and when you find the Wisconsin State Laboratory of Hygiene, click on View Events, and you will find a listing for the afternoon sessions of the WCLN regional meetings. Click on that, and you are going to need a session code for that afternoon session. The session code for the afternoon is 7216. Again, that session code for the afternoon is 7216.